want to start? Yes, I do. Well, hello again. Good afternoon, good evening, good lunchtime, good morning, whatever time of day you're on anywhere in the world. This is the day 4 of the webinar series from the Falls Prevention Network for Falls Awareness Week 2022. Thank you so much for those who have joined and who are joining. Quick bits of housekeeping for you. This is already recording. The recording will be made available afterwards, along with resources sometime next week. You can always go back into the meeting and re-watch it again, as there's the same for any of the other webinars we've run this week. So one thing I will say, we've come to the end of the week now. We've got an online survey. There's a link in the Q&A box, and we will also advertise it a bit later. Please fill in the survey online. It'll take about 2 minutes. Share it with your teams, and we get some ideas of what we've done well and what you'd like to see next year. So I'm going to introduce myself. I'm Neil O'Halloran. I'm the annoying person who keeps sending lots of emails and encouraging you to sign up for the network. It's all free to do that. All these webinars are free. I facilitate the Falls Prevention Network as well as the Harm-Free Care Network. Email addresses and Twitter are in my signature online. I'm going to be ably assisted in the background today by Simon, who's going to help with the Q&A box. We don't use the chat, we use the Q&A. So if you've got a question, pop it into the questions. And if you like something that somebody else has put up there, then just put a little thumbs up for us. And that way we can make sure we get those top questions to Emma at the end. As I said, we are recording. Housekeeping, I would say, normally I say go and get your own tea and coffee because I haven't got any here for you. Do get up and stretch and around and exercise because we can't see you, and definitely keep yourself active. Cameras and microphones are off. Use the Q&A box and like things. Also, don't forget to tweet your activities at Falls_network. And if you'd like to join the network, get in touch with myself. So without further ado, I'm going to move over now and welcome Dr. Emma Stanmore. Emma is a reader in the School of Health Sciences and Deputy Lead for the Healthy Ageing Research Group at Manchester University. And Emma has over 20 years of combined experience in healthcare, research and teaching, with a particular focus on health innovation and the promotion of healthy ageing. And Emma has a passion to avoid hospitalisation by finding new ways of delivering care with the use of digital technologies. So hopefully to take us through all of that will be Emma. I'm going to pop you on the screen and over to you.
So thank you so much, Neil, for that introduction. I'm delighted to come and talk to you today about the KOKU digital programme to prevent deconditioning, falls and frailty. So the plan is to give you a little bit of context about deconditioning, the falls and the current climate. I'll cover the evidence base for the development of KOKU and also the regulatory and data and safety approvals. Now, I'm just going to touch on those, but they're really important for health and social care professionals when they're considering the use of some kinds of digital technologies. And then I'll follow with some completed research on the validation of KOKU and some work on the acceptability and usability testing that we've finished. I'll cover digital inclusion considerations, obviously a big topic considering the pandemic and the digital divide. And then I'll finish with an implementation case study that was recently completed in social care settings, and we've not yet published the results, so that's hot off the press. So just to start, when we're considering deconditioning, what are we talking about? So some people think about disuse, some people think about functional decline. Well, quite recently, the Public Health England have released this definition, which I think is quite useful. It's a little bit more holistic than previous ones. And they discuss how it's the syndrome of physical, psychological and functional decline that occurs as a result of prolonged inactivity and associated loss of muscle strength. Now, last year, we also saw some data released from Public Health England, and this is a publication called The Wider Impacts of COVID-19 on Physical Activity, Deconditioning and Falls in Older Adults. And I'm going to focus, as I mentioned, on the deconditioning and falls. So this data was captured between March and May 2020, where it was found that 30% of older people were inactive. Now that's not that surprising. People were shielding quite a lot over the pandemic, but this inactivity, this 30% with older people was no activity or less than 30 minutes. And of course, the concern there and the work that they've done with modelling is the impact on quality of life, functional decline, deconditioning and falls. And we know that these projected figures are that around 110,000 additional falls due to this inactivity from the pandemic, which is then obviously impacting health and social care and huge costs to the health service. So more recently, Sport in England have released more up-to-date figures, and these cover November 2020 up to November 2021, so a whole year of figures. And these cover all older adults, not just all adults, not just older adults. And they're a little bit more improved, which is great, but not that much more improved. And we can see that there's still nearly 30% of inactivity. And then only 61% are doing an average of 150 minutes per week, which are the Chief Medical Officer's recommendations for activities that you may be familiar with. So these activity levels are still really quite notably lower than they were prior to the pandemic. Now, the impact, again, this might be quite clear to you, but the impact's actually much quicker than that statement I had at the beginning about inactivity over a period of time. It only takes 3 days of immobility to start to see these immediate impacts on cardiovascular, respiratory and metabolic deconditioning, loss of muscle strength and balance, which is the focus of the work that we've been doing. And then there's other things, affecting insulin resistance and increased fat mass and psychological impacts, so social isolation and worsening mental health and well-being. Longer term, that then leads to clinical depression, type 2 diabetes, cardiovascular disease, musculoskeletal problems and falls. And this is where I want to focus now, a little bit more of the data that we know on falls. So a lot of my work's been in, originally it was the epidemiology of falls that I was looking at, and then more recently the development of interventions to reduce falls. Now, reason being is they're the leading cause of injury-related death in older adults, and they're incredibly common. They affect 1 in 3 over 65-year-olds per year, and that risk increases with age. So 50% of over 80-year-olds fall each year. Not all result in a serious injury, but 10 to 20% do result in some kind of major, issue. And of these, hip fractures are one of the most common serious injury. So 95% of all hip fractures are due to falls, and we're aware that they're very costly. They can cost between £14,000 to £26,000, and the outcomes are very poor. So 30% of people die within a year after a hip fracture, and 50% of people never regain their former levels of mobility. So that's some of the impact on the individual consequences. Obviously, the cost of the health and social care services are also huge. This figure of 2.3 billion was an estimate from 2013. They've not yet been released, the more recent figures, but we're expecting that they'll be much greater. And this week, you've already heard a talk about fear of falling. And just to recap on that, fear of falling is a psychological issue. So even with no injuries at all, people can be left with this fear, which then results in more sedentary behaviour and not going out and increasing that vicious cycle of decline. So over the last 35 years, there's been completion of a lot of research looking at the risk factors for falls and the interventions that can be done to reduce them. The NICE guidelines, they were produced in 2013 and they're now being updated, but over the last year we've now seen these global guidelines being released, which I just wanted to signpost you to, and they cover some of the risk factors in the guidelines for practice, and they're very similar really to some of the ones that we've seen before. So we know things like if you've fallen in the previous year, you've got 50% chance of falling again the following year. So it's a really quick question that you can ask people to estimate, what their risk might be. And then some of these other risk factors, they're again quite easy to assess. There are obviously very comprehensive assessment tools, but again, just watching how somebody rises from a chair, you can see if they've got difficulty, they need to push up with their arms and they've got poor balance. Again, really quickly, they've got high risk of falls. So the guidelines for practice, I'm not going to go through in any great detail, but you can refer to some of these. But what's notable, you'll see in the bottom in bold, is there is still a lack of recommendations for any kind of digital tools to support fall prevention. So of all these different interventions, it's a bit of a tongue twister here, so strength and balance programs are the single most effective falls prevention intervention. And we know that now from over 150 completed randomized controlled trials, that these exercises alone can reduce around 1/3 of falls. And that, that makes sense. If you can improve strength and balance, people's response times, coordination, they're much likely to either have a small stumble rather than a full fall, much less likely to have a fracture. So their outcomes are much more greatly improved. And if you reduce a fall, then you're going to reduce these horrendous consequences, such as the hip fractures I've mentioned, ambulance call-outs, hospital admissions. So that's all the background really as to why we wanted to develop a digital application, because my background as a healthcare professional is that I'm aware of the increasing shortages of resources and personnel, and I wanted something that was developed with older people and was safe to use, and that could supplement current practice, not to replace healthcare professionals, but just to either prolong a rehabilitation program, or to enable and empower older adults to use something to self-manage their health. So this is just a screenshot from KOKU, and I'm just going to talk through how it was developed and some of the features, and then discuss more deeply about the implementation side. So here, right at the beginning, we started to work with groups of older people. We worked with over 100 older adults to find out their views about, the design of KOKU, the usability aspects, and what their likes and dislikes. And we also work with healthcare professionals, so falls prevention teams, individual physios, various experts, but particularly later life training. And here you can see Bex Townsley, one of the expert instructors, and she's just demonstrating, how to get up safely from a chair. And what we embedded into KOKU was not just messages about how to correctly do the exercises, but also what not to do, with a view to this being a self-management tool, as well as something that healthcare professionals can use. So there's Bex, she's just done her movements, and here we have our animated character, which people have christened various names, from Wilf to Fred, you name it. Now you'll notice that this character is not, doesn't have the perfect body image. It's a little bit on the round side, it's a little bit comical, and that was again through the choice of older adults. They didn't want to see an image of themselves, they didn't want to see a perfect gym instructor, and so everything that you see is being based on the needs of the older users. We wanted KOKU to be personalised as well. We're aware that people's ability is very wide. Now, bear in mind, KOKU, it's really developed for your pre-frail to moderately frail older adults. It's not for your, your person that's already quite fit and able, and it can perhaps go out and about and take part in usual exercise programs. And that's why we wanted to make sure that right at the beginning, the level of the program was not too challenging or too easy, because again, we know that will make it more likely to be suitable and adhered to. So the person can select a descriptor that most refers to their level of ability. You can see here, I can rise from a chair without using my arms is in green. So click on that, and then their level of ability kicks in. We've added health literacy games and this concept of gamification. Now, gamification is a type of health behaviour change technique or theory. And the idea behind it is that it's not your kind of frivolous, just, a game, although, yes, this has elements of games, but it's things like the rewards, the feedback, being able to nudge, notify people when they need to use KOKU again. So there's lots of things you can add to digital tools that you wouldn't be able to do with a leaflet, because I think that's what I would compare KOKU to, a leaflet, not a healthcare professional, but when you leave a leaflet with an older person, they don't tend to read them, certainly don't comply with the instructions. So this is one of the advantages really of having a digital tool. And then this is a screenshot of a home, the first page that's been personalised. This is John's exercises. You can see there are 3 exercises there. They start with very simple seated routines and then progress to much more challenging routines. They've got a progress screen I'll show you next, various health literacy games, and then there's a full suite of programs that covers 12 weeks of exercises. We've added health validated questionnaires, and this is the progress screen too. So just having a green tick, yes, I've done my exercises for the day, you know, increases kind of self-efficacy and that feeling of, yes, I've achieved something. I know that certainly worked for me when I've tried exercise programs. And the other kind of data metrics that can be captured, we don't always use them, it's whether, because all the data is anonymised, but it can be really useful to see how somebody's progressed. Certainly from, you know, from the healthcare professional side. So we capture things like previous falls, follow-up falls, any injuries, quality of life measures, fear of falling, and that's really interesting to be able to see, you know, what their baseline measures were, and as they use and progress. Now, going back to health behaviour change theory and this I guess the difficulty in getting people to adhere for longer term with digital programs. We're very aware that having some kind of social connection or, you know, doing this within a group is really useful in terms of keeping people engaged. And so our collaboration with Later Life Training has enabled us to be able to add a link to these live movement classes too. And what happens here is that there's a link that you can see there, Dave's exercises, visit live exercises. If they click on that, it takes them to a Facebook page where they can join in 3 times a day with exercise snacks, they're called. And they're just 10-minute sessions at 8 o'clock in the morning, 12, noon and 4 p.m. It's about 4,000 members that are doing this, and they just do some simple exercises for 10 minutes, but it's not a structured program, but it enables people to get some kind of live connection with an instructor and other people. Now, I mentioned at the beginning about the regulatory approvals that are required for digital devices for health and care use. And this may not be very interesting, but it's very important. We want to make sure that, you know, KOKU is safe and that it adheres to all of these. So we worked with NHS Digital, again, right from the beginning. We've got an NHS Digital safety engineer who has assessed and reviewed KOKU and has now approved it has been compliant with these EU regulations. Now, I know we're not working with EU, but we're still having to adhere to these particular regulations to do with clinical safety and data regulations. We've also worked along with NICE with their evidence standards framework for digital health technologies, and this is really to do with the level of evidence that's required before something would be NHS approved. So KOKU is NHS approved, and it's having an independent review as well by ORCA. Now, if you're not familiar with ORCA, they're kind of like the kite mark for digital programs. And ORCA, when they review, they look at 250 different features, things like usability and data safety. So some overlap with NHS Digital, but only 20% of digital applications actually make it through their approval process. So we were delighted that KOKU got such a high score and is out there, if you like, as an NHS approved application. So it's well worth looking for the ORCA symbol, because you can only use it if you've been approved by them. I also mentioned about the importance of digital inclusion, and we're all very aware that during the pandemic there's this huge divide. It became even more obvious with those who have digital devices and who haven't. So we worked with local authorities, and also there's like digital libraries now where people can loan iPads and tablets so that they can use KOKU, so at no cost. And we made sure that it was developed with both iOS, so iPads, and Android devices, so that we can widen access. We've made KOKU available in different languages. We're currently completing an Urdu, German and Chinese version. And we've worked with older people from deprived and socially isolated communities who aren't, familiar with using any kinds of technologies and have multiple morbidities and disabilities, including visual or hearing impairments. And you can see here, this is one of the games you saw near the beginning. This is the one of the home safety games. It's really obvious that yes, the cat might be a hazard, the rug, but some more subtle hazards in there that you may not be aware of. That when a person clicks on it, yes, it's really simple. Yeah, click on that, the cat's a hazard. But there's lots of more value added through putting in more evidence behind some of these home safety modifications that people can put into place to help them become more safe. This is a hydration game, and the reason why I'm showing you this is, yes, being dehydrated does make a person more at risk of a fall and hospital admission, but it's also because we've developed this Urdu version at the moment, and to make an application like this more culturally sensitive, we've considered things like the skin tone and the different foods, and we've had to adapt them. And this wasn't trivial. This actually has taken quite a long time because in the South Asian communities, there's lots of different skin tones. There's different acceptability in terms of what people wear, what food people eat. And so you can see version 2 and version 3 and the different foods that we wanted to put some bits in there about nutrition. And so things like the meat, well, our initial animator showed like the plastic wrapped meat. Well, that's not acceptable, so we had to then change and adapt those drawings. And you can see the dress change from wearing shorts and the character on the right to wearing more full coverage trousers. So there's a lot of work that's been done in that development and design to be as inclusive as possible. Now I'm just going to move on to the research that we've completed, and I've covered a little bit about the user-centered design. Well, we conducted focus groups from the beginning and iterative testing. So what that meant was we would come up with various designs, and then we'd show them back to these groups of older adults living in the community and make adaptations, do a lean, what we call a lean prototype of the digital design, and just keep doing that cyclical process until it was then ready for the early evaluation. And in the evaluation, the initial evaluations that we conducted, they took place in assisted living facilities. So these are older adults living fairly independently, but they had, say, a sheltered housing, a warden, a sheltered housing manager who they could call upon for some support if needed. Some had some home care support, but majority living quite independently, but they would come together in a group and they used KOKU through for 6 or 12 weeks, depending on, there were 4 different studies, unsupervised, but with some support, as mentioned, if needed. And we evaluated things like the acceptability and the usability. And in that study, we were able to also do some measurements of strength and balance. And the results from these studies were all consistently positive. And so then we moved on to an implementation study. So I'll just talk a little bit more in detail. Now, this implementation study, when we got the funding, there was no pandemic, and then suddenly a pandemic hit, and we had to do all of this remotely. So just bear in mind when I talked to you about the results that we had to adapt this. But I think the great thing about doing it during that time, not only was the need obviously very high, but we had to think about how we could, do the training remotely, telephone support. And it really helps now, considering the much wider scale up that we've now been asked to do with the use of KOKU. We use this framework called the NAS framework, which stands for the non-adoption, abandonment, spread and scale up, spread and sustainability for health and social care technologies. Now, there's a lot of implementation science frameworks, but this is one of the very few which, 1, considers technologies, and 2, in health and social care settings. So it's really useful when thinking about not just, how best to implement and some of the issues, but non-adoption as well. Why don't technologies always take off? And we work with 6 care providers within Manchester and Stoke-on-Trent in deprived communities. And we recruited people with this eligibility criteria. We put above 55 years. Majority of people were above 65 years, but you do get the occasional younger person that would benefit. So we kept the eligibility as wide as possible to learn as much as possible. We could have made it, people that would be, most receptive, but we didn't. We had people who did have some degree of cognitive impairment. They just had to be in receipt of home care, so they could have some support if needed, not acutely unwell, and could safely use a tablet. So that's, having sufficient eyesight, if you like, vision, so that they could safely navigate through and use a tablet. They were offered KOKU for 12 weeks, 3 times a week. Most of that was unsupervised, but again, if the carers were going in, they would just nudge or support somebody if they, perhaps forgot to charge the iPad or needed any other type of support. We conducted baseline and 12-week questionnaires. These were all done on the telephone. We were also able to collect data on the care observations as well. At the end of the study, we carried out semi-structured telephone interviews with the older adults and care managers and the carers. So these are some of the results. The mean age was 78, so very much higher than the age 55 eligibility criteria. And as I mentioned as well about the pre-frail to moderately frail, you'll see further down, we actually we assessed the clinical frailty score. That's based on the Rockwood clinical frailty assessment. And the majority of people were between vulnerable to severely frail. We found that this is actually a greater proportion, nearly 30% of people had a tablet prior to us starting to work with them. That's much higher than previous studies, again, because reflecting the pandemic that people were accessing digital devices a lot more. And you'll see that nearly half had a fall in the previous year. So this is a particularly high risk group. High risk, they're frail, they're older, they have on average around about 6 different types of medications. So if you take 4 or more medications, you're more at risk of falls. And 30% of the participants were male. Now that seems low, but actually in recruitment to a clinical study, that's pretty good. And I think men are a little bit more happy to use digital devices. I think because they're just not, as you'll be aware, they're just not so keen on joining classes, or they prefer to exercise alone. So some of the other results we found, we're delighted again that we're getting significant improvements found. Now, do bear in mind that these are self-reported measures, and also this is not a randomised controlled trial, so there's no comparison group. So these are within group measures, but we found that fear of falling was significantly reduced over the 12 weeks, reduced level of frailty, so people's frailty, they improved. They went from mildly frail to vulnerable, which results in them being much more independent in their activity of daily living, so that's a great result. Their mean geriatric depression scale was lower, so they actually showed fewer signs of depression. Again, obviously that depression was much greater during the pandemic. And we saw improvements in their health scores with higher quality of life, higher levels of physical activity, improved pain and fatigue scores. Now these are in line really with what you expect with people exercising. You do get these much better outcomes, but of course we don't know a great deal about the use of digital technologies for exercise. So these are quite unusual, or when I say novel results. We recruited 47 people and 6 withdrew. One of those participants just declined and lost interest, and the other 5, it was due to unstable health problems, which again is not surprising considering the levels of frailty within the group. So the results from the qualitative interviews, the first theme was about the ease of use. Now that's not just considering KOKU, it's also considering the use of an iPad. And we learned quite a lot about people's independent use of iPads within this work. So thinking about the app itself, people found that it was easy to understand. All that co-design work paid off, and that they found that there was no jargon. It's very intuitive and easy to follow. They liked the fact that it was informative, that it spoke to them. So when you download KOKU and use it, the character speaks to you, and there's also written information, and they watch how the character moves. So very quickly they can see how to do the exercises correctly. And they seem to warm to the character too. Immediately when you see people using KOKU, they start to laugh and chuckle, which again, you don't tend to see if you hand somebody a very dry, informative leaflet. Then the second theme was to do with usefulness, and this kind of converted into people talking about how it might improve or did improve their physical and psychological sides, as well as they thought about the educational aspects of KOKU. So on the physical side, they talked about their mobility, being able to walk with greater ease and confidence, be able to stand for longer, to be able to go up and down stairs more easily, which is great to hear. It was also good to hear about how they found they were more motivated to exercise. I think some of the attention as well from taking part in the study would have helped with that, but they, related to the application. And they liked the new information learned from the health literacy gains. Then the next thing was about attitude towards the app and their intention to use after the study. We got good results when referring to the character, as I've mentioned, but some people who were more able did mention about being talked to like a kid. And I think the learning from that is that people who are more able, perhaps with very higher educational levels, may find this is too simple. So that kind of helps us to think about who this is most appropriate for. Other people talked about the issues with using an iPad and just things like pressing the on and off button. That was too hard for some of our participants who were more frail. And so we had to come up with methods to make it easier. We put markers on some of the home buttons and things just to make it more clear where some of these buttons were. And then some users, majority of users talked about the fact they liked the flexibility of use, that they could exercise in their own home at a time that suited them. There was some discussion about the negative issues with classes, that some, the transport issues going out when there's poor weather, that these were barriers, but other people preferred to exercise in a group and would use KOKU with a friend or with a spouse, whilst others, preferred to exercise alone. But definitely a clear theme was about contact with others can sustain motivation. I mentioned about the NAS domains. I'm just going to quickly talk about these. This will be published very soon, so there'll be lots more detail, but this is all about the implementation, considering like from the service perspective. So, who would benefit and the conditions, if you like, that you would consider for use of KOKU. We found that it could be implemented with participants with wide ranges of conditions, but that the suitability was more guided by the perception of the carers or the healthcare professionals. And they would consider things like who would benefit most from using KOKU, and safety considerations and the willingness of the person to use it, which I'll talk a little bit more about in a second. And then the technology, so what kind of training was required. And although the training to use KOKU, it only takes 5 minutes for me to show somebody else how to use it. Those unfamiliar with technology, and that wasn't just the older user, but the carers or some of the physios and nurses, they needed a bit more support because they weren't using the iPads prior to taking part. The value that's listed in the NAS domains talks about the value proposition to both the user and the commissioner or the healthcare professional, and they're different actually. So the user talks more about staying independent at home, and some of the physical outcomes or the psychological outcomes that were reported. Whereas, say, a relative might talk about peace of mind being that value to them. The healthcare commissioner talks about things like the cost of the healthcare service, and the healthcare professional wants to widen the access to some of these resources, or to prolong the offer that they can provide. And then there's other considerations such as the adopter system. And things like the organisation, so people need to have the time to have the training, they need to be willing and ready to implement something like this. And we know from our work with the care providers that there was one care provider where they were so short-staffed, it was just not possible to kind of start working with them. It was very clear from the beginning that they'd lost a manager, and it just wouldn't be suitable. So these are just considerations really when considering doing, implementing something new like KOKU. And then over time, embedding it over time, a finding that isn't reported in the measurements, but it comes out in the qualitative work and our continued work, is that the post-study implementation has carried on, and that does indicate the high demand for something like this. And that's not only just carried on, but some of these services have also recruited coordinators specifically to work with older adults and use KOKU, rather than just embedding it as an additional resource. They've put in it more resources within the team to support the training and ongoing support. So the conclusion from this study is that KOKU can be used as a safe and suitable option for community dwelling older adults. Now, there's other models that we're also testing, and I just wanted to mention a new area that we're working in at the moment is within care homes, and they're interested in using KOKU with their activity coordinators. We've got a current study looking at the scale up of KOKU across Greater Manchester, out in the community, and also with the local authorities, carrying on a bit of the work that I've just been telling you about, but also extending it so that more people, can benefit from it. We haven't yet started, but we have been approached to look at using KOKU for hospital discharges. So as people obviously are in hospital and becoming deconditioned, the idea is to use KOKU before they're discharged so they become familiar with it, and then go home and carry on using it, because again there's just a huge gap there where people are in greater need of this rehabilitation. KOKU can be used independently by older adults and just downloaded from an app store. But that again, it's something that particular people can do. They're familiar with using iPads, but it's not something older adults tend to do, is go, looking on the app stores for something like this. We've got lots of resources now about the training that's involved. It's very simple, but following certain steps does help to make this much more smoothly. We've produced videos and simple leaflets about how to download an app and what the steps are, and who to consider to use KOKU. I mentioned about the highlighting different buttons. It's good to also get hold of antimicrobial bumpers so that if you want to share a device, you want to consider breakages and things. We were quite surprised that none of the tablets or iPads were lost or went walkabout. So we aren't so worried about that in terms of lending out devices. What we have found is that digital champions, they naturally do tend to come forward, but it's a consideration when thinking about adopting KOKU in your practice. The training needs to be thought through, the time, as I've mentioned, identifying patients most in need, and really the messages from the beginning to alleviate any fears about technology are really important. That's probably the biggest barriers that people fear. I don't use technology, I don't like technology. Whereas when you start to show them and they start to build, self-efficacy and self-esteem because they can use it, that can be great because there's added benefits where they can, start to FaceTime family members or, order their prescriptions and things. So just even, putting a bit of time aside to support them with using an iPad can pay off, dividends. And then just explaining the benefits. So don't mention things like falls, but mention things like improving your independence. There's a lot of work that's already been done about, not mentioning the falls word, because that tends to be an immediate turn off for older adults. Agreeing achievable goals. This is well known in rehabilitation, but it follows through with also use of digital technologies. And then the nudging and encouraging, because like anything, it is easy to turn off a digital device. So just a little bit of encouragement or a reminder can go a long way with older adults. And, getting some peer support as well can be brilliant. So family members or neighbours or friends. And then the last bit is about embedding in routine. So it can take 3 months for a habit to be formed. And so if you can help people to just keep using KOKU for 3 months, then it becomes like brushing your teeth. And that's the same with any kind of exercise routine. Not many people like to exercise, but once you get it, it's part of your routine, then it's part of the process. So we've also got some independent reviews of KOKU in research. This is a National Institute for Health research publication where all health and all strength and balance apps, worldwide apps, were reviewed, and KOKU was rated as the top strength and balance app in the UK and one of only 4 recommended applications. That includes web applications worldwide. So you can have a look at that publication if you're interested in finding out more. This is a publication from the US study, and we're interested to see, is KOKU something that can be used in other countries as well? Again, there were consistent findings here with these homebound older adults living in the community, supported by what they call lay coaches. So again, they're a little bit like carers. This is one of the quotes because the character speaks obviously with an English accent. And this US user said, "Oh, fell in love with a British man telling me what to do." That's the little character. He was always there to explain the exercise without the embarrassment of a real trainer. It's improved my quality of life, and now KOKU exercise is the first thing I do in the morning. And that's the bit I was telling you about, the habit formation. If they can get used to using something like this in the whatever time that's convenient for them, get it into the habits, then they're going to get these great outcomes that we want to see. And KOKU had a treatment evaluation inventory score of 73, so a high score there. If you Google KOKU and you go onto YouTube, there's some videos from our users where they talk about how they've used it, what their benefits have been. This particular lady you can see on the screen, she used it actually before she had foot surgery. So she wasn't, one of our typical users thinking about high risk of falls, but it was more of a use in rehabilitation. And then she came back to us surprisingly and wanted to use it after the foot surgery as well. I've added a few resources here, going back to those guidelines I mentioned earlier. So we've got the clinical guidelines on falls and fractures from the British Geriatric Society. There's also some really good resources to do with deconditioning that they provide us. So have a look at their website. There's a link here from the Global Task Force for Falls in Older Adults. You might find useful, Public Health England, and there's just some other resources as well to do with exercise for preventing falls in the community. These are specific publications and peer-reviewed journals for covering some of the studies to do with gamification and the trials related to KOKU. I can't finish without acknowledging the wider team. It's been very much a team sport, developing KOKU in collaboration with Reason Digital, a tech for good company, Later Life Training, who I've mentioned, and I obviously work for the University of Manchester. And there's just been a fantastic team behind all of this. And continuing to support the wider implementation. Funding has largely come from Innovate UK, and they're continuing to fund us. Also the local health, academic health science networks, ESRC, Innovation from Denmark. And that's it from me. I hope that's just a whistle-stop tour about KOKU and the development. I hope there's some wider applications there for other types of digital tools and consideration, for use with deconditioning and falls prevention. But if you'd like to get in contact with me, those are my contact details. So thank you very much for listening. I'll hand back to Neil.
Neil, you're on mute.
I knew I was on mute. I was just like talking to myself. I get paid to do that. It's fun. Thank you, Emma. That was really, really informative. We had a few questions popping up, so if you don't mind, you've got a couple of more minutes to spare, and we can go through what we've collected so far. A technical issue here. I don't know if you've got tech support available to you, but someone's tried downloading the app onto their Samsung S11, fairly new, but no, you've got the response. Your device isn't compatible with this version.
Yes, that shouldn't be the case. I'm not sure what's happened there. Yeah, it's compatible with Android and iOS. It's not compatible with phones. People tend to go straight to the phone to download. We've deliberately not put it onto phones. It's great for finding it, but it's not great for older adults. So again, we found that phones were too small, could be dangerous. Whereas a tablet, it's got a larger screen and yeah, it's more intuitive how we've developed it. We might put some kind of a version on a phone again to widen access, but we just need to be careful about safety. So,
right. Okay. I tried to get it on my iPhone and I couldn't either. So it's like probably as you say.
It's the phone. Yeah.
It's the phone. It's a stupid phone. Tanya, is KOKU available as a free trial for a period of time for healthcare professionals who want to explore the app before signposting it to their clients so they have an understanding how to use it? Just thinking this might be a nice tool to keep people motivated after exercise intervention. We run a 12-week strength and balance program. So just wondering if this app will be useful as a continuation of exercise, or is it best for those wanting to get started?
That's exactly what we want to see, how it should be used. We want people they finish these programs and then that's it, and it's really hard for them to carry on being motivated. So yes, KOKU is available for a free trial. We've actually had it released during the pandemic for free. We've had no problems with that at all. And yeah, if you contact us or look at our webpage koku.health.com, you'll find some information there as well. But yeah, certainly please feel free to use it for free.
And another question, I mean, I think you may have covered it, but there again, people were bobbing in and out, so they may have missed some of the slides. Is there any data to show reduction in falls? I think there was.
Yes, and we're following that up. Actually, we have got a randomised control trial starting in the next few months. It takes a long time to set these things up and they're at great expense, but yes, we will have more conclusive evidence. But the reports from our smaller trials are a reduction in falls. We can't just say that's just due to KOKU. Some of that is because people just become more aware about the risk of falls when you start working with them and start modifying their behaviours. But yeah, we've seen a reduction in falls, and you'll see that 50% of people, nearly 50% of people fell in the previous year, and then in the follow-up, we only had one fall reported, but it was only a 3-month follow-up. You want to follow up people for a whole year. Now KOKU can do that itself if people self-report. So that's one of the things we're looking at in the future, is to be able to pull that data off anonymously, but share that data with health and social care providers.
Just off the top of my own head, thinking about the logistics of this, do you have a sort of centralised portal that all the data geographically comes into you? Is it being analysed on a geographical scale? In which case, do you see any particular trends with particular demographics or in different areas of the country?
Yeah, so that's the future really of KOKU, in that so for instance, we know in the northwest and the northeast we've got much greater numbers of fallers. So the idea will be we're just building a data dashboard where you can monitor and see, the befores and after, and look at regional variations, and also you'll be able to look at should you be supporting certain people and targeting certain people more or areas more. So that's, at the moment we collect the data anonymously. It's kind of your Google Analytics type data, but we will be able to identify people. But yeah, we're doing some work with Greater Manchester and their falls data dashboard, but it's quite complex because of the identification. We've kept it quite simple to date, but that is the next step. Thankfully, we've got funding to do that. So watch this space.
Fantastic. How many of the AHSNs have sort of signed up to be piloting this? Because I know they're very much into their technologies and community. Yeah.
So we're largely working with the Greater Manchester Health Innovation Manchester Academic Health Science Network, and the idea being that will then expand from them. So they're the main users, but we get approached and are working with so like the local authorities. So they're not the academic health science networks, but the local authorities. It's a lot easier then for them to, I guess, work a bit more agilely and sign up to something like this. And then we have just charities using KOKU. So all at different levels, really. Yeah.
Fabulous. Somebody else who said they were late to join, so not sure if this is answered. Is this available per person, or is the single purchase allowed for multiple users? So this is somebody thinking about the ward use environment, and also some follow on from that. Someone's also said, can it be used for groups in care homes as opposed to individually?
Yeah. So the last question is, we're just starting to do some work with some care homes in Salford. And the idea, to use it in a group. They've got interactive tables and obviously TVs where they can link it in and use it as a group. And one of the images showed that's how KOKU was used. There are people in care homes, residents, who can use it individually, so that's absolutely fine. But I think because of the degree of cognitive impairment, most people do in a care home, have some degree of that. They do benefit from supported use. And then what was the other bit, Neil, you're asking?
That was, again, it was sort of multiple use of a single purchase. That was in a ward environment.
Yeah, either fine. So you would license KOKU for larger numbers of users, or an individual user as well. And what we're trying to do is, so we've got this light version that's free, so people can get a bit of a taster. And then if they want to go for the more extended exercise programme, that's £50 per year or £5 per month. That's really, I don't know what people think compared to some of these free apps out there, but that's actually very, very low for something that's gone through all this kind of testing and needs the rigorous ongoing clinical kind of assurance and maintenance. So we do have to put in a charge, even though it's like non-for-profit.
Thank you. Do you have a version for patients with visual impairments like macular degeneration?
The way KOKU is designed is that we've had users with visual impairment use it, and hence having the audio. And the reason why it's on an iPad, that you can get the larger iPads, so according to the individual user. So yes, it does consider some visual impairment. Obviously, if you're registered blind, no, you've got to consider the safety. But yeah, we definitely have tested it with with people with degrees of visual impairment, and there'll be some data in a future publication about that as well, because we've actually measured it as we tested it.
And moving globally, I see obviously you've done the work over in Texas. Is there any moves to any other countries in the world who are going to be taking this up?
Yes, so we've got some work, a Smart Age project in Germany. So it's currently being translated into German, and yeah, they're going to do a randomised control trial over there. So hopefully by next year, this time next year, we'll have some results. So that's Germany. China, we've got some work going on where we're translating it into Chinese. We've done some of this work really for communities over in the UK. So as you know, we've got various Chinese communities in the UK who are testing it, but the idea being as well, we can extend that to yeah, any older person that wants to use it, we'd like to make it available for. So yeah.
Fabulous. Just having a look through, is anything else popped up in the Q&A? I think we may be grinding to a natural halt here. Is there anything else you wanted to add? Oh, hang on. All right, okay, no, it's fine. That's another question. Is there anything else you'd like to add at this point, Emma, before we round off, unless anyone else has got more questions?
I don't think so. I think really what we'd like to see is yeah, people offering it, and any concerns or queries, you can feel free to contact me after the event today. But yeah, really, it's Falls Awareness Week. We want to really, I guess, empower older adults to use something like this and not be put off that it's a technology. I know digital technologies aren't everything, but they do have some good use, particularly when referred to by health and social care professionals.
Yes, and well, as you said, obviously it's not a replacement for healthcare professionals. It's an adjunct to, and just it's another tool in the armoury to try and prevent deconditioning, keep people active.
Yeah, exactly.
Just one more question that's come in. It's to say, could it be? Yeah, could it be prescribed by the GP to keep it free for the end user?
That's what we would love. We want it to be free to the end user. We will, leave it on the app stores for people that in different countries that want to sign up and use it. But yeah, that's the whole idea, is that it will be licensed via the NHS and socially prescribed. So the only thing that's been holding that back is just expanding the team, really. So the more it's used, the more it can be used, and the more we can expand and help to make it more available. So yeah.
Great stuff.
Thank you. We've had a couple of people just saying thank you. Many thanks, well done, and Emma and the team, and thanks, Emma. Really exciting, brilliant job. Both anonymous, so it's possibly yourself typing those in, but
I can multitask.
I doubt
I'm
it.
not that good.
I doubt it.
But thank you, everyone. Thanks for listening.
Oh, hang on, we've got one more.
It's always happened when you tell people you can turn the questions off, they will start coming in.
It's £50 per year for the organisation for licensing. For the organisation for licensing a multiple use, or is it per patient? Is the £50 paid by the professional or the patient, or both?
Yes, so it's £50 for the provider per person, and what we can then do is the more users we can reduce that, and we can also look by payment by results. So that's that needs to be weighed up against the cost of a fall. So if you reduce a fall, obviously these are very low costs. An average cost for something like this is around £12 a month. So £5 is much lower. But yeah, unfortunately, we do have to think about some costs to sustain this beyond grants.
Yeah.
Some more thanks coming in. Seems to be very well received. So if anyone's interested, obviously follow all the links, get in touch with Emma or ourselves, follow the Facebook, Twitter, you name it, it's all out there. I think, unless anyone's going to jump in at the last minute, I'm going to say thank you, Emma, for your presentation and for rounding off a very successful week. And I hope everyone's been enjoying their Falls Awareness Week, and look forward to next year, maybe bigger, maybe better, who knows. Thank you once again, and I shall sign off for now.